complementary processes and what happens. And a lot of what we're going to focus on is not only what is physically happening, but also what is the puppet master behind it, essentially hormonal control of what's going on with these things, okay? So when you see it, I've got my slides color-coded a little bit because what they do is when we get into it, we have overall hormonal control. But then as we're moving into the actual phases of the menstrual cycle, we will digress. We'll go, what's happening in the ovary? Next slide will be what's happening in the uterus. And we go phase by phase by phase. Just so I called it out as far as like color coding on my slide so you can understand exactly what the slide is referring to. Okay? And it'll make more sense again as we get to it. But again, ovarian cycle, uterine cycle, same thing happening in concert, complementary processes, just hormonal control exerting slightly different influence on what exactly is going on. Again, the uterus is preparing for implantation, the ovary is preparing the follicle, as we've already gone through, for eventual ovulation, release, and then hopefully fertilization, right? So, enough, we've already said that. So hormones and menses, we're going to take back. A lot of today is going to be putting our endocrinology hat back on. Okay? So gonadotropin releasing hormone, we know where that comes from, right? Any releasing or suppressing hormone, where does it come from? Inhibiting hormone, generally from hypothalamus, right? To work on the pituitary gland. And FSH, LH, where do they come from? Anybody remember? Which part of the pituitary gland? Anterior pituitary gland, right? Because what's in the posterior pituitary gland?
Everything else.
Everything else? No. Right, vasopressin is one, yes. And oxytocin, yeah. It's in there somewhere. You got to dust it off, shake it up a little bit. Like an estrogen test, you know what I mean? Got to shake it up and not get loose. There it is. All right, so gonadotropin releasing hormone releases or stimulates the release of the gonadotropes. In this case, we're talking about FSH and LH. Follicle stimulating hormone on the male side, right? We're talking about stimulation of what? Huh? Sorry, I don't know why there's feedback. What is stimulation of what on the male side? FSH? S? Spermatogenesis, right? Yes. Easier on this side because it's literal stimulation of the follicle, right? It's what's happening. It's what's producing and encouraging follicular growth, all right? Remember we talked about this part right here, that the granulosa cells do secrete some androgen precursors that then will become estrogens, right? Estrogens as we progress in the follicular development. Does everybody remember that? Okay. Luteinizing hormone, okay, stimulates testosterone production in the male and female. It stimulates development, further development, the end-stage development of the follicle, and eventually the LH surge, which we'll discuss. We look at the hormones and the complementary hormones and their stages at the various phases of the menstrual cycle. You get an LH surge, and that stimulates ovulation. Okay, the actual release of the mature Graafian follicle from the antral follicle, the tertiary follicle. Okay, we're going to talk a lot about the corpus luteum, right? And it's it's easy to remember the luteinizing hormone stimulates ovulation. Then the remainder of that antral follicle, right? We release the Graafian follicle, right? You know that, that's ovulated, taken up into the fallopian tubes, hopefully by the fimbriae, the waves of fallopian tubes. What's left, the follicle remnants in the actual ovary, then become the corpus luteum, the luteal body, okay? And that secretes a lot of our hormones of potential fertilization and then proliferation of the endometrium in preparation for that. So estrogen, high levels of progesterone. Most of our progesterone will come from the corpus luteum, okay? Any interplay of estrogen and progesterone is really important to understand because at different levels, estrogens will do different things. At high and low levels, they will actually stimulate the release of GnRH and luteinizing hormone and follicular stimulating hormone, follicle stimulating hormone. At moderate levels, they'll actually inhibit. With or without progesterone, they'll do other things as well. So the interplay of estrogen and progesterone is fairly complex, but we're going to keep it down on a sort of a ground level here, okay? Relaxin and inhibin we'll talk about individually, but we have discussed them in the past, as far as even in the beginning of this phase, and then also a little bit in endocrinology. Relaxin, it does exactly what it says it's going to do. Relaxes the uterus, also relaxes the pubic symphysis in order to prepare for birth, and then inhibin inhibits the release of other gonadotropes, right? Because if we have successful fertilization, do we want gonadotropes or gonadotropin-releasing hormone to be released? No, and why? Because we don't need to ovulate. We don't need to enter another cycle of follicular preparation and development because we've already got implantation of successful zygote. So we need to halt and arrest that process. And so, again, we'll talk about that as we go through each individual hormone. Okay? Estrogens, similar, a very analogous hormone to testosterone in men as far as what their constitutional and global systemic effects, I should say, are. All right? It similar to testosterone, where testosterone is an anabolic hormone, right? So it builds muscle. So it works in synergy with HGH, as does estrogen in female. Okay? It is thought potentially to lower blood cholesterol. Population-based studies suggest that after a certain age, especially when you're in the range for heart attack risk increase, side by side, females tend to have a lower risk than males. It's thought to be under influence of estrogen. That might lead you to believe or think, well, then why don't we just pump estrogen into middle-aged women to protect them from cardiac risk factors? Well, we changed into a risk-benefit factor, like I just said. Estrogen has its own risk. Unopposed estrogen causes endometrial proliferation, causes potential breast changes, and uterine changes in addition to the endometrium. So unopposed estrogen actually can potentially increase risk for those kind of cancers, right? Because ultimately what is happening in the menstrual cycle as the endometrium proliferates? What is, on a basic level, what's happening? Cellular change. Okay, yes, hyperplasia, cellular change, right? So unopposed estrogen for a long period of time can proliferate that cellular change, and eventually that can go awry, right? So women typically have an earlier menarche, have a longer exposure to estrogen, may have higher risk of endometrial and certain other breast cancers, things like that, okay? Which is why, again, we can't just use estrogen for cardioprotective. There's a risk-benefit, there's a very fine line, all right? And it's also not 100% established if that's the case, that estrogen actually is cardioprotective. But I highlighted this one here for you, again, and we will see exactly what do we mean by moderate levels. Well, I'm not going to go down to the nanogram or picogram level to tell you exactly, like this between this range and this range is low, this range is. At this point, we're just going to use the generic terms high, medium, low, and I'll show you what that sort of looks like on a slide coming up, where we have all the hormones transposed against the days of the menstrual cycle. So just for now, accept that at face value, moderate levels, medium levels of estrogen actually cause an inhibition of GnH and FSH-LH, okay? Because those are, of course, tied together. And why that is will again, hopefully make sense as we go through the individual stages. Progesterone coming mainly from the corpus luteum. Okay, remember the corpus luteum, the remnant of that ruptured follicle that has produced the egg that has been released, okay? It is synergistic with with the progesterone to help proliferate and maintain the endometrium, right? The endometrium, we're going to grow the endometrium in order to prepare it, enrich it with blood, glycogen supplies for the implantation of a fertilized zygote, okay? High levels of progesterone, this will become important, high levels of progesterone inhibit secretion, and that kind of makes sense, right? And even without knowing anything further, if we have a corpus luteum and it successfully it doesn't die, it doesn't it doesn't undergo atresia and go away and then start the next cycle. What does that typically probably mean? It means that fertilization has taken place, right? So if the corpus luteum persists and it's producing progesterone, it would make sense then, if we have successful implantation, that we don't want to start another cycle, right? Another cycle of follicular development, right? Just for the same reasons we just said. Does that make sense to everybody? Sort of? Maybe? You got nothing for me today? Yeah? All right. Relaxin sort of relaxes uterine contraction, sort of facilitates the environment for implantation, and then if fertilization does occur, relaxes the pubic symphysis and prevents uterine contractions during pregnancy until it's time, right? Because when it's time, then we need to have uterine contractions to expel the fetus, right? But until then, we don't want to start premature contractions, so relaxin helps reduce that. Relaxes the uterus, so appropriately named, right? Okay. And inhibin, essentially what we're looking for is inhibition, right? Inhibition of FSH, mostly. Really what we want at the initial stages of inhibin production is suppression of FSH. We don't want to produce too much follicle stimulating hormone because we don't want the patient to enter another cycle of follicular development, but we do need an LH surge in order to do what? What does LH do again? Stimulates ovulation, okay? All right, so let's go through this. This is an encapsulation of everything I said, and these pictures in this section are actually very helpful to just put it all together, I think, right? So FSH, follicle stimulating hormone, stimulates the follicle to grow and mature, okay? Fairly straightforward, all right? When we have the actual ovary now, and ovulation stimulated by LH, so LH stimulates ovulation. And then we have production of estrogen and inhibin by the ovary. See that right here, by the ovary. Now after ovulation, we have the corpus luteum, which is again the remnant of that follicle. And we have a significant increase in progesterone and some estrogen, because again they work in concert, and then we also have increased levels of relaxin and inhibin, all right? So all of this, where everything is coming from is encapsulated pretty well here, right? We don't have much. So what happens let me ask you, where's our progesterone level until after ovulation, until the corpus luteum is produced? How much progesterone is out there? Very little, if any, okay? Very little, if any, because again, where does most of our progesterone come from? Comes from that corpus luteum. So we have to wait until that structure exists before it can secrete its substance. Does that make sense? All right? So what does that mean? That means at that time, prior to the corpus luteum, which happens after ovulation, we have more estrogen than we have progesterone. We have a lot of unopposed estrogen. Does that make sense? Because estrogen is still being produced by the ovaries, by the granulosa cells. It increases after ovulation, but we have estrogen and no progesterone before ovulation. Clear? Clear? Yeah? I see you walking yourself through it. Tell me. I mean, it doesn't have, so okay, that's a great question. I say that sort of like you guys understand what I mean. Typically when we talk about unopposed, we talk about unopposed by progesterone, because they can have complementary but also antagonistic effects, depending on their effect on the hypothalamus and the pituitary. So right now we have estrogen without progesterone. Okay? Does that make sense to everybody? All right. Is this clear enough? I mean, I know for a fact that you're going to have to digest it, you're going to have to look over this a couple of times for it to make sense, but it is not as complicated as it seems. Is anything unclear right now? Yeah.
Can you just restate that you said?
Which one?
Estrogen is unopposed.
Yes, right now, before we have, you know what? I'm going to do this. Give me 1 second. So, this is the slide I was talking about that I was referring to. The maroon or dark red dotted line, that's progesterone. Okay? We're talking about ovulation happening on about day 14. Okay, so look at the progesterone level up until day 14. There's almost none, right? But look at the estrogen level. The estrogen is the green dotted line. We have estrogen and it is actually increasing up to about day 14, and then it drops a little bit. So we have, this is what I mean by unopposed estrogen. We have a lot of estrogen and not much, or if any, progesterone. Does that make sense? You guys? Can you see that over there? Okay. There's a lot of estrogen, almost no, if any, progesterone. So that delta between here and here is unopposed estrogen effect. Okay? Does that make sense? All right. Let me pretend like I know which slide I was on before. Hold on.
184.
Oh, yes. Okay, good. Any other questions? Okay. All right. So now we're going to dive into it, put some pieces together, a little bit of a deep dive. Phases of the reproductive cycle. So we are going to, this is important, we're going to start with bleeding. I know that sounds tongue-in-cheek, but menstruation is day 1. Okay, it's evidence of the start of the menstrual cycle. Does that make sense? All right. Pre-ovulatory. What do you think is happening during the pre-ovulatory phase? In the ovary. Let's just stick with the ovary. We're making the new follicle. Exactly. We're follicular maturation and development. Exactly. Pre-ovulatory phase. Then at ovulation, what's happening? Rupture of the follicle and the release, and then the production of what? The corpus luteum. Exactly. Right? And then the post-ovulatory phase, we're going to put some layers on that. It depends on, of course, that forks into fertilization or no fertilization. And we'll put those layers together as well. Because obviously, they're two very different pathways. If we have no fertilization, what happens? Back to square one. That's a great way to put it. Degeneration of the endometrial layer, degeneration of the corpus albicans, or the corpus luteum and the corpus albicans, start the cycle over with menstruation, right? If we have fertilization, we have implantation, well, we have a very different pathway, right? Okay. Now I want you to look at this, and I know it seems complicated, but it's actually a very, very good encapsulation of everything. And I want to draw your attention to a few things before we move forward with this particular slide, okay? All those phases that I was talking about were here: menstrual, pre-ovulatory, ovulatory, and post-ovulatory. This is how we're going to really delineate the majority of the progress, all right? The slides are going to be named for those phases. Also, what I want you to look here. We've discussed the ovarian cycle, what's happening in the ovary, what's happening in the uterus. Then we have here, you see something called the follicular phase and the luteal phase. Okay? Then you also see the proliferative phase and the secretory phase. Now, the secretory and proliferative phases are in regards to the endometrium and the endometrial growth. The follicular phase and the luteal phase have to do with what's happening in the ovary, right? The follicular phase is the growth of the follicle, and the luteal phase is after the corpus luteum exists, after ovulation. So it's not, even though there's 7 different ways to annotate or think about what's going on here, if you really just look at it at face value, especially all together like this, it kind of makes more sense, I think. Now we're going to tease apart all of this over the next 4 slides, but you remember whatever I put together, I can't even remember what I was doing, but it was like this slide. It was like inspiration and respiration, inspiration, what happens in inspiration and exhalation. Like I said, the next 35 slides are this picture. That's the same thing with this. The next 35 slides are this picture. Okay, and if you can sort of understand what's happening, and just the picture alone really does help, right? So we start at day 1 with menstruation, bleeding, sloughing of the endometrial lining, right? evidence of start of a new phase. As menstruation is happening, the body understands now what? There was no implantation or fertilization. So what is happening in the ovary? We're starting the cycle over. We're preparing for the next phase of ovulation, right? After menstruation happens, now the hormones are starting to increase. What is happening? Endometrial lining is starting to get thicker and thicker and thicker in preparation for hopefully this time the released Graafian follicle being fertilized and implanted, right? Then we have ovulation occurring, corpus luteum being produced. We're going even further as far as endometrial proliferation in the secretory phase. Let me tell you guys this now. Secretory phase has nothing to do with bleeding. It has to do with the secretion of glycogen and other products in preparation of the endometrium for implantation. All right? And then if it doesn't happen, then again, we start the cycle over. If it does happen, regarding meaning fertilization and implantation, then we take a different pathway. That's an encapsulation of the whole thing. I know that's a very easy once around the world, but does that kind of make sense? At first glance? Sort of? Okay. All right. So, this kind of just goes over what these other phases mean. Menstrual and pre-ovulatory, we know that. We haven't had successful implantation, and now we are preparing a new follicle for release. That's the follicular phase. When ovulation occurs, and after, we have the corpus luteum, that's the luteal phase. And what are we secreting during the luteal phase? Progesterone and more estrogen, right? Progesterone especially goes up because we have a corpus luteum. Pre-ovulatory phase, I don't know, these are out of order. I probably should have put those back in order, but proliferative phase. In a pre-ovulatory phase, we're preparing the field for play, right? We're preparing the endometrium for implantation. In the post-ovulatory phase, it's preparing for the final stages. Now, the follicle's been released, swept into the fallopian tubes. If it's fertilized, it's going to be on its way down. Now we need to have products in the endometrium ready to accept that fertilized zygote, right? That fertilized egg. And so now the secretory phase has to do with, again, like I said, secretion of glycogen and other products, not having anything to do with menstruation. People confound those a lot and think the secretory phase equals the beginning of menstruation and bleeding, and it does not, so just get that out of your head now, right? Sir? Yes?
You said you needed to switch pre-ovulation and ovulation.
I just think it would make more sense if it went a different way. Because there's follicular, because again, follicular and luteal, these are ovarian processes, right? And these are uterine processes. So there's not a good way to split them. They don't, like those don't go in 1, 2, 3, 4, 5 order the way the other ones does. Does that make sense? Because follicular, luteal are up here, proliferative and secretory are up here. So it's just meant to sort of transpose what section is happening where. Does that make sense? Okay. So anyway, this one just sort of calls out, again, products in the ovary, products in the uterus, events in both. So you're going to, again, I know we have 50 slides, about 20 of them are going back this again, this again, this again. So we're going to hammer this one home. Yeah.
So the question here, uterus is growing.
Yes.
Physically.
The lining of the uterus is the endometrium. Yes. Okay. So growing in, I guess, is the best way to say it, right? When your uterine cavity, the endometrial lining, the endometrium, what is that? It's the inner lining of the uterine cavity, right? The wall of the uterine cavity. That is growing and proliferating with tissue and blood supply and glycogen and other products that are going to help it accept as zygote for fertilization and then let it grow, right? And then that's the portion, that endometrial lining is what sloughs off. The stratum functionalis, if you guys remember me talking about the functional layer versus the stratum basalis that doesn't move, doesn't slough off, that's evidence of menstruation. That is what happens. That's the menstrual period. Okay? Does that make sense? Okay. So again, all I did was color code it so you can see it. It kind of translates better, I think, on the large screen down. It's just so you understand. We are now talking about the menstrual phase events in the ovaries. Does that make sense? So we're talking about like days 1 through 5. What is happening in the ovary? So, what is happening in the ovary? We've already talked about it. Menstruation in the uterus is evidence that we didn't have fertilization. So what is the ovary doing? Making a new follicle. Exactly, making a new follicle. Getting ready for the next ovulation. That's exactly what's happening. Alright? So while the uterus is sloughing off the old lining that was not utilized for its intended physiologic purpose, the ovary is getting ready is preparing the next follicle for the stages of maturation that we talked about in the last class. Does that make sense?
College is expensive.
It is expensive. You thinking about another pathway, another career pathway? All right. Does this make sense? Right? Everybody? This makes sense, right? Yeah, that's what's happening. This phase is what we discussed in length as we went from the stages of follicular development, from the antral follicle and then to the Graafian follicle that it's actually released. Now, uterus. What's happening in the uterus? Prostaglandin. We're talking about prostaglandins a number of times. There's a lot of cellular mediators that have a lot to do with vasodilation, vasoconstriction. Okay, in this case, we have vasoconstriction of the spiral arteries. Do you remember what the spiral arteries were? I'll show you on the next slide in case you don't. They're those arteries that go into the stratum functionalis. Okay? So, if we have that functional strata, that stratum functionalis of the endometrium, that is being supplied by those spiral arteries, and now the spiral arteries are being vasoconstricted by prostaglandins, what's going to happen to that tissue? It's going to die and slough off. It is programmed apoptosis, programmed necrosis of that tissue and sloughing off of that lining, the stratum functionalis, leaving just the stratum basalis. Does that make sense? You guys remember that? Okay, that's menstruation. All right? And why are we while I'm on here, why are we having declining levels, do you think? I know we haven't got there yet, but I did mention it. Declining levels of progesterone and estrogen. What's degenerating? The corpus luteum is degenerating. Our primary producer of progesterone is degenerating, right? And those theca cells that are producing some of that estrogen are declining because the egg was not implanted, it was not fertilized, it undergoes atresia, regression, and dies. And so now the corpus luteum becomes the corpus albicans. We haven't got there yet, but that's exactly what happens. That's the thought pathway, right? So we have those declining, and now that kicks off those prostaglandins. So again, everything's communicating. The ovaries and the uterus and the hypothalamus and the pituitary all communicating together to do these things in concert, even though they kind of are separate processes. Does that make sense to everybody? Okay. So, in case you don't remember, these are the spiral arteries, right? So we start with the stratum basalis, right? This darker red portion under here. Right? Those are fed by straight arterioles, in case you don't remember, right? The spiral arterioles then go and proliferate into this stratum functionalis. All right? So then if we don't have any implantation, this layer is what sloughs off and is represented by menstrual bleeding, right? Because these arteries constrict and don't feed this tissue, and so it dies and it is shed. Okay? Make sense? And again, we went over the menstrual phase. We have primordial follicles maturing into primary and secondary follicles and so on and so forth. All right? That's the menstrual phase. Does that make sense to everybody? I know it's not probably going to stay. It's not going to stick with one go, one pass. But is there anything that's very unclear? That's really what I'm trying to get at. No? Okay. All right. pre-ovulatory phase now. Back to the ovaries, okay? Pre-ovulatory phase. So we have finished the menstrual phase, days 1 through 5 essentially. We're moving into the next phase. Right? In the ovaries, now we have secondary follicles. Right? They start to secrete that estrogen. Where we talked about those granulosa cells start to secrete some estrogen products and some inhibin. Right? So now we went from not having much estrogen, so we're secreting a lot of FSH and LH. That started the process, especially FSH, that started the process of this follicular development. Now we have a maturing follicle that is secreting some estrogen. What do you think that translates into my low, moderate, high level of estrogens? Now we're at moderate, okay? Now we're at moderate. At low levels, estrogen will have a positive effect, a positive feedback to release more GnRH and more FSH-LH. At moderate levels, estrogen will impede or inhibit the production of GnRH and FSH-LH. Does that sort of make sense? Right? Because we have a follicle that's becoming the dominant follicle that's maturing, and so now we don't need to start the process over. We don't need to start maturing any other follicles. Somebody asked me, do both ovaries ovulate? No, one does. Essentially, it's a race of those follicles to see who can get to maturity fastest. The other ones on the other side of the ovary undergo atresia. The other follicles that did not become the primary or the mature follicle undergo atresia in the ipsilateral ovary. One mature Graafian follicle is released. All right. Essentially, it becomes a race to who can produce the most estrogen the fastest. That's the maturity. The evidence of maturity that then inhibits other follicles and allows that one to continue in the process. Does that make sense?
So are both ovaries producing primary follicles?
Yeah, both ovaries are undergoing this process, but only one is going to make it to the finish line. Yeah.
One follicle from one ovary
Will release. Yeah.
status.
Well, in one ovary will get it to mature status. So it's gonna start to inhibit FSH and LH. Look at the bottom before let me answer your question here. Right? Right here, day 10, multiple secondary follicles are going to be produced, but one is going to make it to that tertiary stage. Okay, does that make sense? Is that what you're asking?
Yes, sir.
Okay, yeah. So multiple primary follicles are going to become secondary follicles. Only one secondary follicle is really going to progress past that. Okay? Right? And maybe that's all we need. Right? And if we have multiple ovulations, then we start having twins and things and so on. But again, at that point, when we have a mature follicle that's still now it's producing moderate levels of estrogen, we don't need other follicles to keep maturing. We've got one. Is that clear? Sort of? Yeah.
So is that gradual spike, so here, pre-ovulatory, around day 10, we're at moderate, correct?
Yeah, sure.
So,
No, yes, we are.
so, is it the saturation of that single secondary follicle that's going to be secreted, basically overrides all of the
More or less, as it releases more and more of its estrogen products, it goes from a low level to it continues to be a moderate level, because then every secondary follicle is secreting a little bit of that estrogen, and as they go away and die, that one continues to mature and secretes its estrogen, so it stays at sort of that middle layer, all right? I'll show you more, but is that what you're asking? Essentially, even though we have secondary follicles falling off, we still have this one that's continuing to mature and secrete even more estrogen-type products. That's leaving us at this sort of relative medium level of estrogen that's still inhibiting. And that's going to change here in a minute when we go into what's more of a high estrogen status without progesterone yet. So give me 1 second and we'll get there. Does that make sense?
Yep.
All right. Any other questions? Okay. So, still in the ovaries, this is again going along with the question. The dominant follicle becomes the Graafian follicle. It doesn't matter if it's 20 millimeters. That's not important to me. But ultimately, this is what I think that you were asking, is again, as it gets bigger and bigger and more mature, it starts to secrete more and more estrogen. So it's keeping, even though we're losing secondary follicles, estrogen production remains about the same until it continues to mature and then it goes up. And so we go from moderate to a more high estrogen level. Does that make sense? Anybody? Yeah, all right. And I think that wraps up most of the questions. Is everybody sort of on the same page now as far as what's going on? Multiple secondary follicles, all secreting some estrogen. One wins the race, becomes a dominant follicle, goes into its tertiary follicle stage. Its estrogen secretion continues to increase as it gets bigger. So we're going from low to medium, now we're approaching high estrogen. Does that make sense? High estrogen, what do we not have yet? Progesterone, right? Exactly. Okay, and that's important in a minute. Events in the uterus. What's happening? As all of this is happening, we're in the pre-ovulatory phase. So we're in the proliferative phase, right? And we're focusing just directly on the uterus. The stratum functionalis is growing. Does that make sense? That's what this whole thing says. The endometrial lining is getting thicker. It's proliferating in preparation for ovulation and then ultimately implantation. Okay? Does that make sense? This is why unopposed estrogen can have negative effects, because it induces cellular change in the endometrial lining. So early menarche means more periods, and I don't mean menstrual periods, I mean more like just time, temporal spaces of endometrial change and growth over a woman's lifetime can lead to an increased risk of something going awry in an endometrial cancer. Everybody know what I say when I mean what I say early menarche? I mean somebody that has their periods early, let's say 11, 12, 10, something like that, right? Depends, fairly early on, they have more cycles, then this patient has more periods of cellular change, potentially exposure to more increased likelihood of endometrial cancer and neoplasm, all right? But focusing on this is non-pathologic, this is supposed to happen, right? We're preparing the endometrial lining for implantation, acceptance of that zygote. Does that make sense to everybody? Doesn't matter. I don't care that 4 to 10 millimeters thick. I don't care about that. What I care is that you understand the process. Well, the follicle is maturing, it's secreting estrogen. That estrogen is causing the endometrium to grow. Does that make sense? Okay. And again, we all understand, of course, the difference between the stratum functionalis and the stratum basalis, right? Functionalis so appropriately named because it's functional, right? It has a purpose, and if it's not used for that purpose, it's lost, whereas the basal layer, the stratum basalis, is always present. Okay? All right. Again, that's where we are here, right? We're up to about like right here. We have a mature follicle, and we have proliferation and thickness of the tissue, right? Easy enough? Ish? Yeah. Okay. Ovulation phase, right? Now we have a dominant follicle that ruptures and is released into the pelvic cavity, hopefully swept up by the fimbriae into the fallopian tube. Right? That's ovulation. Okay. Now, call your attention to this. We have moved from moderate estrogen level to high estrogen level. Okay? Again, relative term, but just remember, low, medium, high. We're at high now. So, this is important because it causes unopposed estrogen, meaning estrogen with no progesterone, actually causes a release of GnRH and a release of luteal hormone, luteinizing hormone in particular. Follicle stimulating hormone still remains relatively low, but luteinizing hormone increases. What did I say luteinizing hormone does? Ultimately. Ovulation, it causes ovulation. Does that make sense? The mature follicle causes a surge in LH, which then ultimately allows it to rupture and be released. Does that make sense? While maintaining a relatively low level of follicle stimulating hormone, because again, what do we not need to happen at this point? Follicle stimulation, right? We don't need to grow another follicle because we have one ready to go. We just need to let it out. Does that make sense to everybody? Okay. All right, good. And that's what this means. GnRH produce increased release of FSH, but it does technically increase a little bit, but this one goes way up. And that'll make sense when we see that graph again. So really focus at this point on the surge and the increase of luteinizing hormone, okay? Clear? Were you guys with me? You had anything? Okay, good. What's up? I see you're smiling. Is that a good smile or a bad smile, or is it just a like?
GnRH promotes the release of FSH and luteinizing hormone, but in this instance, it's just not as much.
Much more luteinizing hormone,
Is there
right?
something else that changes that ratio, or do we not care about that?
We don't care about that. Right? What we care about at low levels, what it ultimately, here's what it boils down to. I'll tell you. What it boils down to is at low levels, it will increase both dramatically. At high levels, estrogen by itself preferentially increases LH. Okay? And I'll show you again, I'll show you, I have a graph with positive and negative feedback stuff, I'll show you that. Just accept that fact. Low levels, we want FSH and LH because we need to make a new follicle. High levels, we have a follicle ready to go. Ultimately, that's what's being communicated, in the positive and negative feedback loops. We have a follicle ready to go. We just need to release it, all right? So preferential release of LH. Does that make sense to everybody? Okay. That's the legitimate answer to your question. Like biochemically, why does that happen? I don't know. Ultimately, it's because we don't need another follicle stimulation. That's really what it is. That's what it boils down to. Okay. And it is partially related to that inhibin as well. And the inhibin's also happening in the background with the release of that follicle. So it does have a counterproduction of keeping FSH down. All right. We don't need to overcomplicate the issue because the face value is good enough right here. Does that make sense? Okay. All right. Ovulation phase in the uterus now. So ovulation in the ovary, ovulation. Got it. All right. High levels of estrogen. Now we are trying to get that LH surge. In the uterus, basically, it's just a continued proliferation. Okay? Just nothing special. Just getting thicker. Okay? The spiral arteries and the endometrial lining regarding the stratum functionalis are growing. Okay? This is what you can tell your patients if this is about the time you can detect LH surge, right? But right here, this is where it's happening. Ovulation about day 14, right in the middle. So we have our ovulation, right? And then this corpus hemorrhagicum is what it's called because it bleeds after it opens. It becomes the corpus luteum. All right? What? Good? Good. All right. Now, pay attention to this. This is not happening in both ovaries, right? It's happening in the ovary where the corpus luteum exists. And where does the corpus luteum exist? In the ovary that ovulated. Okay? Minor point, but it's physiologically very important for you to understand that, okay? So, we have the rupture of the antral follicle releasing the Graafian follicle, which is the mature follicle, right? Haploid ready for presentation of the sperm, dichromal reaction, potentially fertilization, okay? The cells become the cells of the, again, it's called the corpus hemorrhagicum. You don't, that's not necessarily important. It's because the antral follicle bleeds, and so it's called the bleeding body. Doesn't matter. It becomes the corpus luteum, right? It doesn't exist as the corpus hemorrhagicum very long at all. But it comes to corpus luteum, which then gives us a lot of our hormones that are going to prepare us for endometrial growth, enrichment, and implantation. Okay? This is the big one that we start to receive now, right? Now we have a corpus luteum. So now we have progesterone. So then I say unopposed estrogen that doesn't exist anymore, right? Because we have estrogen and progesterone in the mix. Okay? Any questions on this one? We're going to stick to the ovaries here for a second. If, pay attention, in the post-ovulatory phase we are not fertilized, this is the easy one to understand. That corpus luteum begins to degenerate into what's called a corpus albicans, a white body, right? Think of it, it's just as a degeneration, it's lost its rich tissue, blood supply, so on, so it just sort of undergoes atresia and involutes and just eventually dies off. What does that mean? It means progesterone production starts to decline, so on and so forth, right? So, and remember what I was just saying, at low levels of estrogen now, because we don't have a follicle, we don't have really anything secreting much estrogen, we want these to rise, right? So again, high levels of estrogen without progesterone, and low levels of both include induced secretion of GnRH, FSH, and LH. And in this case, FSH and LH in basically equal parts, because we need to stimulate another follicle maturation. Does that make sense? Again, we're starting the process over. What this is encapsulated is the ovary recognizes that fertilization implantation has not happened, so it communicates to the hypothalamus and the pituitary, we need to start the process over. That's what's happening here. Does that make sense? In ovary specifically, corpus albicans degenerates, dies, and goes away. Okay? Does that make sense? Okay. Corpus luteum doesn't die immediately. Just so you know, it does have about a 2-week lifespan. But again, it's shrinking, dying, right? We can't have it die immediately, because if we do have fertilization, which does not necessarily happen immediately after ovulation, it has to persist. But again, after fertilization, there's communication and hormone release that suggests that we need to proliferate the corpus luteum, and that's going to come up in the next slide, where we talk about if it's fertilized. Okay? So, same ovary that was ovulated. Now we have fertilization that's occurring. All right? We get the ovum, which is the precursor to the zygote, the second polar body, which is just leftover genetic material. Now we have a diploid zygote, right? We have a little human, basically, who's a little ball of cells that's about to become a human. The corpus luteum, it lives on past its 2-week time period, its typical 2-week lifespan, because of human gonadotropin, beta HCG, right? Which is secreted by the cells of the zygote. Specifically the chorion, which is the outer membrane, right? But now that, again, that's the chemical signal to proliferate and persist the corpus luteum to continue to make the hormones necessary for continued endometrial proliferation, right? It's a mouthful, but does that make sense to everybody? Right. And again, it's this HCG that allows the corpus luteum to persist, to live, not to degenerate into the corpus albicans. So again, just to go over one more time, and I know it's break time, just give me 1 second, we'll do this and then we'll break. We've got no fertilization, basically the corpus luteum lasts for about 2 weeks, degenerates into the corpus albicans, stops secreting its progesterone. Now we have low levels of estrogen, low levels of progesterone, so it communicates to the hypothalamus to release, gonadotropin releasing hormone. Let's surge FSH and LH, make a new follicle, start the process. Over. Okay? Fertilization occurs. The zygote chorion, the outer layer of the zygote, begins to make HCG. That allows the corpus luteum to live and continue to produce the stuff that's needed to continue to proliferate the endometrium, because now there's a little person growing inside of it, and so it needs to continue to proliferate. Does that make sense? All right, we'll stop there for 10 minutes and we'll come back and we'll finish up, all right?
Yeah, I see what you're saying. The answer is yes. I see what you're saying. It's the end of the first cycle. The intervening portion is getting into the next actual cycle. So that's yeah, no, yeah. So yeah, what you're saying is technically. So the follicle is like phase zero. Is that all that's essentially? That's the first ovulation. The first ovulation. So it feels like yeah, exactly. Yes, ma'am.
On your slide, the ovulation phase is pregnancy test. I thought they detect
It can detect the surge of LH, but it also primarily detects HCG quantitative HCG.
okay,
I might have.
like the home tests that just detect
Tests that detect ovulation. Yeah, that's what. So now I guess I should just. It's not a pregnancy test. It is like basically somebody who's trying to plan for ovulation.
Okay.
So the LH surge, so they know that.
that's what I was trying to do. Okay.
No. I need to. Yeah. I'm sorry. I need to. It's not. I need to clarify that. See that has a double layer there? Check it outside. Once subject materials inside goes into primary. Yeah, there's still DNA. Oh, and that little happy medium where you know, for the most part, this is essentially fertilize the year. Once it attaches to that, dude, there's like 15 names right now. And now it's 77. Palmer's orders, it says nothing about BS. It says nothing about fuels being hard. But his guy, he's going to be BS. You know, I tried to go talk to them. They did it this morning. They were doing some stuff. Yeah, they said that. Yeah. So it's just like, every time I went there, for me, it's like you do like 4 or 5, all of that. Yeah, it's because that's the people that like they said for you had a couple last nights your house, got your backyard, going meals provider. And it's not 70 pH. It's all good. It's been my his orders are exactly the same. So I tell you what, there's and I'll check out that. I'll check out my sister, my brothers. At one point they had that for kids, they but it's all out of the way. You know that it's like, that's the thing. Probably but at least it does. I cannot imagine. All of a sudden, no, you're right. Yeah. So I'd say I would I'll go back and be like, the other trailblazers, this is all 6 years old. Oh, thanks. Either way, okay. I try. Okay, that's great.
right here, somebody, I should change the nomenclature, not a pregnancy test, basically, they're tests that can detect ovulation. So patients that are looking for fertilization, trying to get pregnant, if they're having difficulty, they can buy a home test and detect the LH surge to know ovulation is occurring, so that's their prime opportunity to try to conceive, okay? So not a pregnancy test that, of course, like we said, it detects HCG, right? So just to clarify for everybody, does that make sense? But again, there are tests that you can help with patients that are having difficulty with these tests, so that they know. We'll talk about some birth control methods. Okay. All right, post-ovulatory phase in the uterus, continued thickening of the endometrium because we have the persistence of corpus luteum. All right. And then if fertilization does not occur, what happens in the uterus? What happens to that stratum functionalis? Goes away. Exactly. Goes away. Okay. All right. So this corpus luteum and the secretion of the estrogen and progesterone products causes a continued proliferation, thickening of the endometrial lining. If those are withdrawn and this becomes what? What does the corpus luteum become? The corpus albicans. Then we get to this bottom here, cessation of progesterone, significant decrease in estrogen back to low levels, and we start the process over. Okay? Does that make sense? All right. So, if we have no implantation, luteum degenerates after about 2 weeks into the albicans. Now we have estrogen drop. That causes prostaglandins to basically cut off the blood supply to the spiral arterioles, and they lose their ability to continue to stay alive, and they menstruate, right? They are sloughed off in that menstruation, and then we go back again. If you see, this is day 1. The beginning of the bleeding is day 1. All right? Make sense, everybody? That's the cycle. It's gonna take a few times through to tie that down. And if you get to tripping points, please let me know. Of course, I'll go over it again. But again, I think this is a good picture that encapsulates the entire process. Yeah. There's no difference. It's just bleeding starts at day 1. It's just sort of a picture of the fact that day 1 begins. I mean, it's basically the same thing. Right? It just shows you going back into another cycle. Right? So it's the end and going back into another. Okay? Now this is back to the hormonal regulation. Alright? Hormonal regulation. Again, here, before we have any, let me go to this. Here, before we have any progesterone, we have some, again, moderate level of estrogen. Right, so we have a dip in LH and FSH, right? Because moderate level of it. We don't need to start the production of another follicle. Then as that follicle matures and starts to release an increasing amount of estrogen, without any progesterone, we have a high level of estrogen, which leads to a slight bump. Remember, now, does this visualize this better for you? We have a slight bump in FSH, but a huge bump in LH. That leads to our menstruation. Okay? So a preferential increase in LH. We have unopposed high estrogen, no progesterone. Right? We have this at about day 13, because what happens at day 14? Ovulation occurs at day 14, or thereabouts, right? So about 12 and 13, we have this huge LH surge that leads to rupture of the follicle and ovulation. Okay? Then now that we have a dramatic, what's increasing this progesterone here now that we've ovulated? Corpus luteum is producing progesterone. The ovum and the follicle are still producing estrogen. So we have estrogen and progesterone. What happens to LH and FSH? They die down. Why? Because we don't need spreading just yet. We have to give a chance for fertilization and implantation to occur. Okay? And then if it doesn't, things happening here, this progesterone decline and this estrogen decline. The corpus luteum is declining, right? Starting, I mean, it's got 2 weeks, right? It's going to live for 2 weeks, but if we don't have recognition of implantation, right, it's going to start to decline into the corpus albicans. That's going to drop our progesterone, our estrogen, and then what's going to happen on this side? What is exactly happening here, right? It's going to start to go up so that we start to stimulate another follicle. Yes?
So is there any hormonal changes for ectopic pregnancies, or is it while you're...
It's the same thing, right? The same thing happens. It'll still be secreting beta HCG, so you're still going to have recognition of this process is going to be essentially the same. What's going to happen is implantation is going to be a spot. So progesterone will be different, but essentially the hormones are not going to be entirely different than what happens in a normal pregnancy, right? Anybody else? Yeah. Which one? The second rise of estrogen. This here? Basically, the proliferation of the corpus luteum secretes estrogen as well. So the corpus luteum sticks around, and then the actual secreted ova secretes some estrogen from that corona radiata around it. And, well, I mean, not just those two things are responsible for its death. Why does it decrease around day 14 here? The estrogen decrease around here is because essentially we have the follicle, then the rupture of the follicle. So that follicle, it doesn't immediately turn into the corpus albicans. So we have the corpus luteum, so we have a slight decrease because then really what's happening is just the corona radiata is secreting around here, and then as the corpus luteum sort of picks up and is able to start secreting, then again we have this sort of gradual increase here. Does that make sense? Okay. Yes.
So is it around like day 14 to day 20 that's when the egg will kind of go into?
Yeah. So at 14 we have a release of the ovum, right? We have a release of the Graafian follicle. Around the next couple. I mean, it shouldn't take a couple of days to get into the fallopian tube. But yeah, that's when it's moving into the fallopian tube and moving its way down into the uterine cavity itself. Yeah.
I'm sure it doesn't have anything to do with like sustained life, but like, can the albican be fertilized?
No.
Have
The corpus albicans? No, it's not. It doesn't have any egg. It doesn't have any nuclear material in it. The second polar body has deteriorated. Once the Graafian follicle is released, the corpus albicans and the corpus luteum are just the structure surrounding the egg, or what was the egg. Yeah. Anybody else? Okay. So that's hormones. Again, very good interposition here. Sometimes you just take that one slide that I spent all that time on and put it next to this one. It helps to carry through of what's happening where as far as the hormonal regulation. This also does a lot of back explaining and answers a lot of the questions that you guys have asked along the way, right? So green indicates positive feedback. So low levels of progesterone and low levels of estrogen on this side right here, right? What is this indicating? Essentially, the start new follicular phase, right? We have no estrogen, no progesterone because we have had atresia of the Graafian follicle and the corpus luteum into the corpus albicans. It's suggesting we haven't had successful implantation, so start a new cycle, right? Low levels indicate that. Now, as we are starting and we have a maturing follicle, we get back to this moderate level. And what did I say moderate level does to FSH, LH, GnHRH? It inhibits it because we have a follicle that's developed into our dominant follicle, so we don't need any more follicular development. Then we have that follicle that is progressed and is about to now ovulate, to be released. It's releasing a lot more estrogen because it's become big and mature. Now we have high levels of estrogen with no progesterone, again, because we haven't ovulated yet. That increases our levels and gives us our LH surge that then leads to ovulation. So if you unpack this, it helps to go over everything that we just went over again and again and again. Does that make sense to everybody? You guys? Sort of? I mean, I get it. I know when I say does that make sense, it might not. But is there anything that is very, just really cloudy, unclear, muddy right now about this process? Okay. No, I mean, trust me. There's no, I mean, unless your photographic memory are just really a lot smarter than me, it takes more than once to go over that stuff to really get it down. But I think that if you tease it through, and just look at those slides as you're looking, you transpose that slide with the word slides, if you want to call them that, it walks it through pretty well and sort of makes sense. Okay, guys? All right, this is about, we are in the home stretch, all right? Birth control methods, all right? Lots of, we're going to do an amazing amount of contraceptive management counseling with your patients, and vice versa. You're going to do a lot of fertility counseling with your patients about how to successfully achieve pregnancy. We've already talked about a number of things that you can do for your patients to have them have the optimum successful chance, right? Get varicocele fixed. Don't drink, smoke, reduce your cardiometabolic risk factors, exercise, have a healthy, yada, 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 right? Some things you would think that you would not have to tell a person, you're going to have to tell a person. That condoms really do decrease your chance of pregnancy, so stop using them if you want to get pregnant. I've had to have that conversation before. Okay. Spermicidal lubricants, like if you're using a lubricant during sex and it has spermicide in it, because it says it on the bottle. Spermicide kills sperm cells, which are necessary for pregnancy in general. Again, keep your game faces on because some of the stuff. I mean, honestly, because one of you're all very intelligent people, or else you wouldn't be here. And so if you're anything like me, your natural inclination would be like, "Are you serious?" But that's not. Don't do that. You know what I mean? So let's talk about sterilization. We're talking about things that get to nearly 100%, almost 100%. We're talking about vas deferens ectomy, right? Vasectomy, we're cutting the pipe that brings the sperm cells to the ejaculatory duct. Right? Again, needs to have a post-vasectomy semen analysis to make sure we have none. All right, and then there is still a possibility that they might go back together, although highly unlikely after that post-vasectomy semen analysis if you confirm 0. All right, tubal ligation. Exactly what it sounds like. Ligation means technically to tie. Right? The fallopian tubes can be tied, clamped, prized, often done after birth, immediately after, since the patients are there sometimes. But again, gentlemen, just so you know, significantly higher morbidity, or not morbidity associated with this, a lot more complications, a lot higher potential for significant blood loss, infection, and pain post-tubal ligation. So pound for pound, side by side, vasectomy is a much easier and simple procedure, just so you know. Hormonal methods, all know about birth control pills. What they do, as you can imagine, is keep our estrogen at a moderate level, and then inhibits the gonadotropin release hormone and then the FSH and LH, so we kind of stay out. It's almost like that. It's almost like we always have a dominant follicle, right? So we sort of reduce the chance of going back into that follicular phase and then growing more follicles. That's sort of how birth control works. Progesterone only, which we use a lot for patients who have higher risk factors of thrombosis, or smokers. We use a lot of progesterone only because it has a lower risk factor of thickening blood, clotting than estrogen-containing birth control pills do. That really doesn't have the same effect, of course, it has nothing to do with estrogen, but what it does do is make the cervix and the endometrium unfavorable for implantation. So that's how it works. Okay? As far as benefits, when I say non-contraceptive benefits versus risk, that has nothing to do with the chances of contraception. It just has to do with the sex or the risk factors associated with these pills. okay? So benefits, a lot of women enjoy a regulation of their menstrual cycle. There are pills where you can predict and determine the number of cycles you'll actually have per year. There are some that will turn the cycle off completely. Some women do like that, okay? It is useful for acne. It is useful for menorrhagia, which is a heavy flow or higher or more often bleeding. Menorrhagia or menorrhagia, bleeding too much, bleeding too often, that can help that. It can help with menstrual related pain. It can help with endometrial pain. Okay? Non-contraceptive risk, the main one is people with clotting factors. Estrogen-containing compounds do increase risk of thrombosis, spontaneous thrombosis. Again, which is why smokers who have an inherently higher risk of thrombosis because of thicker blood, because they are at a chronically lower oxygen level, so their EPO levels go up, and so they make more blood cells, so they have an induced polycythemia, meaning too many blood cells. We don't want those blood cells bumping into each other and causing clots with an increased risk of estrogen. So it's very important for you guys not to remember what I just said, but to remember that after pharmacology, and then when you get out of counseling with your patients, it's very important that you make sure that you take a good social history and find out exactly what they do as far as smoking, nicotine use, so on and so forth. Okay. IUDs, intrauterine devices. A lot of women like these a lot because they don't have to remember to take a pill, honestly. Okay. They're implanted in the cervix, into the uterus, into the endocervix, and then they have little hooks on the outside. It looks like a T. Hooks on the inside, I guess I should say, the hook into the uterus itself. Depending on the type, it can be a copper IUD, which lasts up to 10 years. That sort of makes the cervical mucus unfavorable for implantation. It changes actually the electrochemical gradient of the cervical mucus. Or you have hormone extruding ones, like Mirena is one, that actually do extrude, low level over the time of estrogen and progesterone. So excuse me, similar to oral contraceptives, just you added benefit of not having some type of pill. Okay. The Mirena lasts 7 years. So that's another good thing for these patients. They put it's introduced and then contraception for 7 years. Now, of course, you have to educate your patients that contraceptive is one thing, STI prevention is another thing. So you have to tell them that if they're having multiple partners, still utilize a barrier protection to avoid STI, but they're very convenient, as it were, for contraceptive methods. Some of the things that aren't on here, also Depo-Provera. I don't know if you guys have heard of Depo-Provera. It's a shot. All right, it's on a schedule for your patients. It's also it's got some associated risks with osteoporosis, but there's multiple different things you guys will learn about Depo-Provera and Farm. There's a NuvaRing, which is a cervical ring, hormone extruding cervical ring. Actually goes over the cervix and extrudes hormones similar to an IUD. Some women like that because they can fit it themselves. There is an implantation called the Nexplanon. It's actually about the size of a grain of rice that goes into the forearm that extrudes hormones as well. So a lot of these implantable devices, IUDs, Mirenas, or IUDs, Nexplanon, so on and so forth, they have an added convenience factor that the women don't have to worry about it, and a lot of times it does control their menstrual cycle, so they don't have to worry about that either. And so lots of different options for your patients, lots of different options. The Mirena IUD is one of the closest to 100%, like 99.7% effective. So also very effective because then when you have a pill, you have to consider that with your patients, the reliability of your patients that are going to remember to take that pill every day at the same time. All right. So spermicides, again, you can buy, that's over the counter stuff that you can buy. The spermicidal lubricated condoms, of course. Condom, we have the barrier protection. We need that added protection of a spermicide lubricated on the outside of that condom. Then you have just barrier lubrications that include spermicide and so on. A lot of men will find that, actually not a lot of patients, whether they're the men or their partner, will find that non-oxynol-9, which is one of the more common spermicides, that has a high degree or a high incidence of contact dermatitis. So your patients will sometimes be experiencing redness and itching after after that. Okay, so a little bit of steroid cream and that'll go away, but then avoid that. Okay, it's usually not a very severe allergy, just irritating more than anything. Barrier methods we talked about. Condom, female condom exists. Diaphragm, which again fits over the cervix, so that you prevent the entry of the sperm into the cervix. And then you have a cervical cap, same thing but more rigid. All right. Again, it's just like a diaphragm is like a little condom that fits over the cervix. The cervical cap is a little more rigid, a little less comfortable, from what I understand. Diaphragms. You don't find a lot of people that use diaphragms anymore, but they do still exist and they are still an option for your patients. And then you have the rhythm method and the symptothermal method, all right? So remember all the way back we talked about middle schmerz, that sort of increasing body temperature, basal metabolic temperature. Patients sort of have the middle of the abdomen, lower pelvic pain that sort of indicates ovulation, which means you should not have sex for a few days after that because that's when the egg is traveling and ready for sperm. So if you have your patients, some of your patients will advocate for that for whatever socio-political or religious reasons. And so just educate them on the necessity of the timing, understanding. The woman really needs to understand her body and the signs of when ovulation is occurring. Otherwise, it's a highly unsuccessful method. Okay, obviously a lot of user error there, not to be tongue in cheek, but it's just true. And then just to, not to use this as a birth control method, it's just as a caveat to another slide. If you want to talk about what abortion is, it's typically the loss of the fetus before 20 weeks, whether spontaneous or intentional. Okay? And so you guys will talk about the different types of abortion, whether they threatened, spontaneous, inevitable, when you get to women's health. You talk about different types, because there are different types. In this case, we're talking about either spontaneous, meaning a miscarriage is the colloquial term for it, or intentional loss of custody via a medical abortion. Okay? And those can be done with medications to induce or through actual surgical invasive procedures. Okay? Any questions about birth control stuff? All right, aging in the reproductive system. Last two. So fertility goes down, even though we've said, of course, fertility for a male patient, a male human lasts from essentially puberty until they die. That doesn't mean the quality, motility of those sperm is equal across that entire time period. So as that patient gets older, you have reduced seminal secretions, right? So some of that seminal plasma stuff from the bulbourethral from the prostate, they decrease, which then decreases the viability and the lifespan of the sperm and its ability to survive. Again, quality of production of sperm sort of decreases, and so you'll just get. And then, of course, with females, you have a finite number of ovulations that will occur after menopause. Then fertility is a non at that point for the female population. Okay. We got, as we get a surge, of GnRH, because we have a decline in estrogen and progesterone. Estrogen specifically, that surge of GnRH is associated with what are specifically known as a hot flash of perimenopause and menopause. Right? Because we have a severe decline in estrogen production, because we have a loss of ovulation, and our ovaries are starting to shut down that period, that follicular phase. We're no longer entering it because we're no longer ovulating. We have a finite number of those things. So GnH surges, because we have a continually low level of estrogen, causes those hot flashes that are pretty pathognomonic for menopause and perimenopause. And then estrogen, as some of you may know, as women age, advance in years, they're more likely to develop osteopenia and then frank osteoporosis that has to do with a lack of estrogen production. Okay. Other things that can happen is you can get vaginal tissue atrophy because of a lack of estrogen. So you can have increased incidences of incontinence, urinary incontinence, because you lose the bulk of the vaginal tissue that's sort of buttressing the urethra. And so if you have that, atrophic vaginitis is what it's called. Patient can be supplemented with topical estrogen to help rebulk that tissue and use that. So that's just some of the things that occur. with females aging, we talked about with guys. Again, reproductive lasts until they die, essentially. And I put down here, essentially, what really happens when you start to lose testosterone around, it is a natural decline. You might hear it as andropause, analogous, process to menopause. But you have a natural decline in your testosterone, which then leads to a loss of muscle mass, an increase in the ability to accumulate fat, tiredness, fatigue, so on and so forth, right? You see the loss of muscle mass. You guys have seen old men before. They look like frogs standing on their hind legs. They have no butt anymore. So they got. Also, I have potentially with the two asterisks. Aging does not potentially bring prostate growth. Aging absolutely brings prostate growth. But what does not happen absolutely is our symptoms that go along with that. And we have talked about those in multiple blocks. You have the encroachment of the prostate tissue in the urethra. Every man is going to experience, every patient with a prostate is going to experience prostatic growth as they age. But not everybody is going to experience encroachment on the urethra. And not everybody's going to experience it to the degree where it causes obstructive urinary symptoms. Does that make sense? So benign prostatic hyperplasia is almost essentially universal, but symptoms are not universal. Does that make sense? Let me put a bow on that. Your prostate's going to grow, but your pee might still come out just fine. Okay? Yeah.
Back for the aging and for the women's reproductive.
Like this is the last slide. I don't have any time for questions.
I know. I'm sorry. What's up? I just know you're ready to just pop out. That's all, folks.
Yeah. What's up?
For the birth control that stops ovulation, when that inhibits that process, if they stop taking it, does that mean that they'll have ovulation longer until?
No, because the hormonal change is still going to occur. Like you're not going to be able to prolong your I see what you're saying. So if I start birth control from age 16 until whenever, I'm not gonna gain those back in 10 years or 20 years. No, that doesn't happen. You still get the hormonal changes, and you just undergo natural atresia of the ability for those follicles to develop. So yeah, it doesn't happen. All right. Any other questions? All right. That is all, folks. We got a lab tomorrow. I do want to say this, digress into a bit of seriousness before I let you off to lunch. All right. I had a lot. I enjoyed this for you guys. I really have enjoyed this. I had a lot of sort of trepidation about leaving IPAP proper and leaving clinical medicine, teaching clinical medicine, and not seeing patients anymore. Because I thought teaching A&P was going to be pretty boring, you know what I mean? But I couldn't have asked for a better group to start this with, because it sort of helped cement and solidify the decision. I had a lot of fun with you guys, and you guys, hopefully, at this point, I don't say things if I don't mean them, meaning I don't blow smoke up your ass. So I wouldn't even bother saying this if I didn't mean it. You guys have developed a very good class personality, so I would encourage you to try to maintain that as you move forward. You start to get tired of each other after a while, but at least I haven't seen, or the faculty hasn't seen any infighting or bickering or nonsense that occurs a lot of times in the freshman semester. So good job. These guys, when they cross service, you'd be surprised. The Army and the Air Force are very small places. The PA is even smaller. As you stand longer and longer, it becomes even smaller than that. So these are going to be your colleagues moving forward in the future. You never know who's going to be there for you for a job interview or a recommendation or be able to get you somewhere. So just stay tight, y'all, because this place will give to you. All right, the doldrums will come in IPAP. The thing I'll leave you with is when the doldrums come, and they will, just remember why you applied to come here in the first place, and keep that as your motivation to keep driving forward and running your head into that same wall over and over again. All right, because it doesn't last forever. All right, and if I can do it, y'all are way smarter than me. You can definitely do it. So just keep moving forward, y'all, and thank you very much.